also hold webinars.
Good evening all, Chairman Sir, Dr. Rawat, and our revered teacher, Dr. S.P. Balasubramaniam Sir, esteemed guest speaker from UAE, Dr. Kalpana Sengupta, and all my EV colleagues and friends. This is a very important session, and this is a monthly RESPINAR series from IAP NRC, and Dr. Kalpana Sengupta. She is going to discuss two very interesting pediatric respiratory cases, and to have his expertise, his wisdom for this scientific session, we have one of the finest and most revered, illustrious teacher and a very celebrated figure in medical education in our country, Dr. S.P. Balasubramaniam sir. So to start with, introducing Dr. Kalpana Sengupta. Now she is the head of the Department of Pediatrics, consultant pediatrician in NMC Specialty Hospital, Dubai. Though her 40 are pediatric nephrology and intensive care, but she is here in our forum to discuss important cases, interesting cases in pediatric respirology. She actually was there in our country, and she graduated as MD from Bombay University in 1993. DNB again, National Board, New Delhi. She was here for as assistant professor also, I think in SETGS Medical College, Mumbai. And she is now also the president of Dubai Pediatric Club, right, Dr. Ma'am?
Secretary.
Yeah. So thank you for accepting our invitation and to be on this RESPINAR series. Now, to introduce, he actually doesn't need any introduction, but sir, he is now the visiting consultant in pediatrics and former medical director, Kanchi Kamakoti Child's Trust Hospital, Chennai. Also a trustee in Child's Trust Medical Research Foundation. He is also the head of the Academics Institute of Advanced Pediatrics, Rela Women and Children's Hospital. Honorary Pediatrician, Southern Railway Headquarters Hospital, Chennai. He has already more than 150 indexed publications, mostly concerning pediatric infectious diseases, and not less than 40 orations. That is stupendous for our sir. And his interests are pediatric infectious diseases, PG teaching, as he is known by this thing, and vaccine research, COVID-19. So he will be the expert for our session. Now, with our welcoming words from our chairman, sir, we'll go on to science.
Thank you, Dr. Modi, and I will welcome all the distinguished office bearers and faculty members, particularly Dr. Kalpana and Dr. Balasubramaniam, for this important meeting. RESPINAR, as you all know, this is a meeting in which we invite some overseas delegates who present some important topic discussion or some case discussion on some important respiratory problem. So this edition we are having Dr. Sengupta from Dubai, and straight away we'll go to the session. I'll request Dr. Modi to start the session, please. Thank you.
So, ma'am, nothing in between science and yourself. So over to you. Thank you.
Thank you, Dr. Modi. Thank you, Dr. Balasubramaniam. I'm very, very honored to be here. Thanks for the invitation. And like Dr. Modi explained, my heart is in nephrology, but being a pediatrician, being HOD pediatrics, we have to deal with all kinds of cases. So today I am going to present two cases, and I will start with the first one. Just sharing my screen now, so please let me know whether you all can see my presentation. Is it visible?
Not yet.
What about now?
Yes, ma'am, now.
Please make it, yeah.
Okay. Just a minute. Yes. Please excuse me for this. I don't know why I'm going in and out of this. Okay. So starting with the first case, both these cases are very recent, in the month of February, in fact. This is a 12-year-old boy who presented in the middle of the night to our emergency with fever, cough history, acute history of 2 days, and increasing swelling and pain in the left eye since 1 day. On examination, this boy was pretty obese. He was about 96 kilos, and he was febrile with significant swelling and redness of the left upper and lower eyelids. There was chemosis, mild proptosis. However, eye movements were full and free in all directions. The child had frontal sinus tenderness on examination. His nasal passages were blocked with purulent secretions, and his throat was mildly congested. His ears were normal. Respiratory system examination showed just occasional harsh breath sounds. The other systems were normal, sensorium was normal, and there was no focal neurological deficit. So this is not the picture of the child in question, but this is a picture from the net. I just wanted to show the redness and the swelling of the left upper and lower eyelids. The index case also that we are discussing had similar swelling. However, his conjunctiva was reddish, and there was swelling as well. So this child was admitted, IV antibiotics were started, ceftriaxone and linezolid in high dose. He was given supportive care. Now, an ENT opinion was taken in view of this frontal sinus tenderness and a severe presentation. The ENT opinion was that it is a severe acute sinusitis, probably with left periorbital cellulitis. The ophthal opinion revealed a left preseptal cellulitis. They agreed with our initial diagnosis, and they specifically noted that the eye movements were preserved. The vision was 6/9 in the left eye. At this point, we decided to go ahead and do a CT of the left orbit with paranasal sinuses with contrast. Now, this was planned. However, this was a private case, and the parents were really hesitant. So we had to really, use all our communicative skills to make them understand the importance and the urgency of this investigation. And yes, after good counseling, they did agree, though a couple of hours passed before they could, say yes to us. Meanwhile, we had done an X-ray of the sinuses, and that showed right maxillary and left frontal sinus opacification, suggestive of sinusitis. His total WBC count was 18.5 with 82% neutrophilic response. The CRP was 98, PCP was 0.69. His X-ray test revealed mild bronchitis. This is his X-ray sinus picture, which shows the left frontal and right maxillary opacification. And this is the X-ray of the child. Once the CT was done, it showed pansinusitis as clinically was expected. There was a left infraorbital extraconal well circumscribed, mildly enhancing oval heterogeneous fluid density mass light connection, which was measuring 23 by 31 by 13 millimeter. This was causing mass effect over the left eye, causing the whole architecture to be distorted. Outward and inferolateral displacement was seen. There was a suspicion, they said, could be subperiosteal abscess of the left orbit with pansinusitis. Initially, they said that there could be a small radiodense bony ossicle that was query foreign body, but on review, this was found not to be one. Minimally reactive decuscystitis with tiny abscesses in lower eyelids were also reported. So these were the picture. We can very well see the proptosis that is obvious and the displacement over here with the fluid-like density in the left upper part of the orbit. Now, at this point, it was still put down as a left preseptal and periorbital cellulitis. Left lamina pepritia appeared to be thinned out on CT, and they advised to go ahead and do an urgent USG or MRI orbit. To be very frank here, it was really difficult to get one neuroimaging done, and to go ahead and do the second one. It was extremely difficult for us to convince the parents, and at this point, they took independent opinions from India and other parts of the GCC, where they had some relatives, and they were told not to worry, as this is a common condition, can be easily managed, and your doctors might be unnecessarily too worried about it. Meanwhile, we could just not wait, so we had told them that this child would need urgent surgical exploration, and we would have to drain the pus out. At this point, the father decided to take the child to India. He actually had booked his tickets, and he was not willing to listen to anything and said that, no, this can easily be managed with just medicines. And then we, in between, had done our CBC. He was reassured by the total WBC count coming down to 11.8. CRP was still high, PCP was 0.43. And there was initial clinical improvement with reduction of eye swelling and redness after 24 hours of antibiotic treatment, which was expected. However, we had informed them that this child needs urgent surgery. Within a couple of hours, while they were deciding, they were actually booking their tickets. When we examined the child again, the child said, I cannot see. There was an acute visual loss. He complained of vision loss, and his eye movements were restricted by then. They were convinced, they were told that he will have to get operated here itself. Urgent ophthalmic evaluation was done, and it revealed drastic reduction. If you remember, initially the vision was 6/9, but at this point the vision had dropped down only to finger counting at 4 meters, and there was significant retinal hypoperfusion, and there was a suspicion of left central retinal artery occlusion, which is a very rare complication in view of the sudden vision loss in this child. So this is the initial retinal photo, which shows the significant hypoperfusion. They were given a very extremely guarded prognosis at this point, and then obviously keeping the urgency of the situation in mind, they agreed to get the further treatment done in UAE. Urgent PES was done, that is the functional endoscopic sinus surgery, to relieve the globe compression secondary to pansinusitis. Globe decompression was done. Ethmoid and sphenoid sinuses were drained. On day 1 of the post-op, the vision improved quite well. From 6/9, it had gone down to finger counting at 4 meters, and it improved up to 6/18. So about 60% improvement was seen. Nevertheless, his ocular movements were free except for limited abduction. Retinal perfusion was much better. Chemosis, conjunctival congestion, and periocular edema was decreased. The eye movements were still restricted, And at this point, we got our blood culture back, which showed S. pneumoniae, strep pneumoniae, which was sensitive to ceftriaxone and linezolid, which had already been started for this child. It was decided then to do, this is just a pictorial depiction of the functional endoscopic sinus surgery. If there are any junior doctors attending, it is good to know what we are subjecting our patients to. Hence, it's just when the patient's parents want some explanation, it's good to have some basic diagrams to show them. As the picture depicts, the sinuses are filled with mucus and the endoscope is put in and the obstruction is relieved so that there's a free flow and there is no external cut. It's an endoscopic surgery. At this point, we decided to go ahead with an urgent MRI of the left orbit and paranasal sinuses. But there was a suspicion raised of cavernous sinus thrombus, or rather we wanted to rule it out because that is one further complication that could take place. So we decided to go ahead and include MRI brain and MRV as well to rule out cavernous sinus thrombosis. Now, this is a beautiful depiction, very clear picture. If we see the left orbit, it is the swelling is seen very clearly in the superior to the globe, and the globe compression is seen very clearly. So this child was again urgently, this is the MR brain and MRV, which were normal. So MRI showed the same mass with mild reduction in globe compression. The globe compression did, like the architectural configuration improved a bit, but not much. There was a soft tissue swelling, which was slightly reduced compared to before. There was evidence of pansinusitis. Optic nerves were normal, and the recti muscles were bulky. So MRI brain and MRV was normal. This child was again reshifted to OT, and a complete orbit decompression was done. By that, what do I mean? The lamina papricia itself was removed. There was a deep dissection done towards the left orbital cone with complete removal of the collected pus, and also the recti muscles which were entangled were freed. Now, again, at this point, to be very frank, I had forgotten my anatomy that I had learned in first MBBS, so decided to freshen it up with what is actually lamina papricia, because when the surgeon said that he had removed a part completely, I needed to know for myself. And this is a pictorial depiction again. This is the medial wall of the orbit. It has a convex rectangular shape, runs parallel to the sagittal plane. This convexity becomes particularly prominent in the mid-orbit. Now, if you see the lamina papricia, it is literally forming the medial wall, and it is paper thin. So that is very close to the ethmoidal maxillary suture line. So this is the frontal view, and this gives us a better idea because we can see the sinuses and then we can see the lamina papricia next to it. So they had to actually go behind, break through that, remove the pus. A deep dissection was done, and this was both these surgeries, so to say, were urgent organ-saving procedures. Post-op, the eye movements were completely normal. The vision progressively improved back to 6/9. The retinal perfusion improved. However, the child still had left eye ptosis. There was a suspicion of residual cranial nerve damage. The pediatric neuro opinion was taken. They added vitamin B12 to the treatment. The repeat total count of the child was 12,000 with CRP of 28, and the blood culture by this time had shown no growth. So this was the repeat picture of the retina that had shown good perfusion. On further follow-up, this child's ptosis started resolving, and he remained afebrile, he remained infection-free. He is under follow-up still. So when we talk about respiratory cases, we focus a lot on the lower respiratory tract. I decided that sinusitis, which comes to us pediatricians more often than not as a common outpatient case, it's probably good to highlight a case wherein a severe complication and a rare complication has taken place, and to probably go through certain points which we need to remember as practicing pediatricians. Now, orbital septum is very, very important. Why? Because that's what differentiates our grades of orbital cellulitis. And going further to this picture, we can appreciate how the septum and the sinuses, how close they are, in close proximity to each other. And this will take us to the classification of these cases. When we assess them, how should we assess? So what are the red flags concerning orbital cellulitis? So before this, I go one step back and say that whenever we see a child with periorbital redness, swelling, proptosis, chemosis, we must always look at the contiguous structures, the sinuses which are next to it, like the frontal sinus, ethmoidal sinus, maxillary sinus. We must examine them and rule out that the infection is not stemming from there. Because unless until we do the primary source control properly, we are going to have progression of this illness. So what are some of the red flags concerning orbital cellulitis? If we notice that the child has painful or restricted eye movements are very important to be checked. So that's the first step. If the child has visual impairment, that means reduced acuity, relative afferent pupil defect, diplopia, proptosis, or a severe headache or other features of intracranial involvement. This is the famous Chandler's classification, grade 1 to grade 5. The grade 1 is preseptal. If you see, the red portion is showing us the cellulitis, yellow is signifying pus, and the dark maroon is showing thrombosis. So if we just take the grade 1, group 1, which is preseptal. So I am already shown the pictures of orbital septum, which if it is in front of it or posterior to it. That's how we decide the grading. So group 1 is the least in severity, and group 5 is the complication you don't want to see, that is the thrombosis, including the cavernous sinus thrombosis. Group 2, the inflammation or the cellulitis has progressed further. In group 3, the pus starts forming, and in group 4, it is abscess formation as well. Now, this is for again the junior doctors to remember. I would read this from down upwards. When we examine the child, go to the lowermost part of the slide, which says minimal swelling, able to open the eyes, and you're able to assess the eyes, and the child is systematically well, yes, then first also consider allergic reaction or manage as mild periorbital cellulitis, depending on further history and examination. The second group is a moderate swelling, reduced eye opening, but able to assess eyes, systematically unwell, fever lethargy is there, yes. This should be managed as moderate periorbital cellulitis. Third group is age less than 3 months, significant swelling, unable to perform adequate eye exam, inadequate immunization to hip, then manage as severe periorbital cellulitis. Going further, the danger signs of proptosis, decreased visual acuity, the tenderness, restricted eye movements, severe or persistent headache, manage as orbital cellulitis. And then finally, unwell or septic looking, obvious sepsis, manage as sepsis. So these are the clinical classifications that should be there. in your mind, you should run through them, look for the clinical symptoms and signs that fit the child into a particular category. Going further, a beautiful depiction, a very simple way to remember the types that we have gone through already. The black bar is representing the orbital septum. Inflammation without pus is seen by the red box, and the green is inflammation with pus or abscess. Now, if you just see the type 1, it's preseptal cellulitis. Inflammation does not extend beyond the orbital septum. Type 2 is the postseptal or orbital cellulitis, where the inflammation has gone beyond or into the orbital tissues, but there is no abscess formation as yet. Type 3 is subperiosteal abscesses formed from deep to the periosteum of the orbit. And type 4 and 5, where it progresses further with formation of orbital abscess. Abscess forms within the orbit with breach of the periosteum, and then finally going into the cavernous sinus thrombosis. Now, in this child that we had, the progression of signs and symptoms was pretty fast. In fact, the decrease of the vision that happened from 6 by 9 to 4 meters finger counting within a span of 1 day or so, that was surprising even to our ophthalmologists. So that is something to keep in mind, that they have to be admitted, they have to be under close monitoring. So this is going back to just showing how close the nerves, our sinuses are close to the nerves, and how the infection can spread from one to the other, and involving all the signs and symptoms and the complications that we may come across. So having dealt with this case, it got us thinking just to do a little literature review to know how often can we expect this, what is the literature saying about the incidence, what is the literature saying about the prognosis, and came across quite a few surveys or reviews which were over a period of 10 to 12 years. So coming from good hospitals. So like the one right now on the screen is was done at St. Louis Children's Hospital. This was from 1st Jan 1990 to 31st December 2002. So a long enough period to evaluate the frequency of intracranial and orbital complications. So in this, what they found was that they had divided the children. They had a clear distinction, less than 7 years, more than 7 years. And they felt that when they reviewed the data, the complications were seen more in older children, more so in adolescents. So patients with dual complications, the mean age was found to be 15 years, 16 years. They were more often than not males. They had subperiosteal abscesses located superiorly or superiorlaterally within the orbit, and they presented with significant frontal sinus disease. Now, as far as the sinuses are concerned, different studies have implicated different sinuses. So obviously, as we know the anatomy now, we know that it could be any of the sinuses or all of the sinuses involved in such cases. One fact that came out repeatedly was MRI was superior to CT, obviously for identification of the intracranial extension. So simultaneous intracranial and orbital complications are rare, but significant occurrence in acute pediatric rhinosinusitis. In fact, a lot of studies have shown that in severe acute rhinosinusitis, the children are more likely to get complications than adults. So being pediatricians, we have to keep this in mind. Because of the high incidence of intracranial findings, it is recommended to do MRI in addition to CT, along with aggressive management in children older than 7 years of age, admitted with orbital complications of acute rhinosinusitis, who also demonstrate risk factors for intracranial disease. So this was one. This was another study which reviewed the demography, microbiology, and outcome data. As far as the microbiology is concerned, the bacteria, different bacteria have been implicated. However, the streptococcal group is found more often than not. Strep pneumoniae, as in our patient, and strep viridans. These were the two. Here it is strep milleri, which is nothing but another form of strep viridans. So this was found. And here 144 patients were reviewed, and they had the complications like orbital cellulitis in 51 cases, orbital abscesses in 44, epidural empyema, subdural empyema, intracerebral abscesses, meningitis, cavernous sinus thrombosis, and Pott's Puffy tumor. So this was about the microbiology. The prevalence of orbital complications among children and adults, I've already touched upon this, that the children are found to be more susceptible to progress and complications. Acute bacterial sinusitis and its complications in a pediatric ENT department between 1997 to 2006. So a similar data and the complications, they say, are challenging, but the prognosis can be favorable. So yes, but when it happens, the things unfold so fast that you have to be on your toes and take the appropriate action. So some of the things to remember: the orbital septum differentiates periorbital and orbital cellulitis. Visual symptoms may be often a late sign. So you have to proactively act when you see the redness, swelling of the lid edema itself, and not wait for the visual symptoms. Repeated assessments can be crucial for diagnosing complications, should be part of the management of the child. If there is no improvement in the clinical state of the patient 24 hours following the initiation of medical therapy, then imaging is warranted. CT is inferior to MRI in the diagnosis of intracranial pathology. Early signs of cavernous sinus thrombosis may not be present on CT imaging, and the presence of an abscess normally requires surgical intervention, as was clearly seen in our case. We had to go in again and do a surgical intervention for the abscess. So progressing on to the second case, which is, I wouldn't call it very rare. It is actually one of the common cases that any of us practicing pediatricians would encounter. Just need to highlight a thing or two. So this was a 7-year-old boy who presented to us with fever, cough, right chest pain since 5 days. His oral intake was poor. He did not have breathing difficulty. He was initially treated at a clinic. The child, when he came to us, he was not breathless. He had no respiratory distress. He definitely had signs of pneumonia on examination. And as shown in this X-ray, you can appreciate that he also had blunting of the right CT angle. So his X-ray chest showed haziness in the right lower zone. The right CT angle was obscured, because of which ultrasound was done, and it revealed minimal effusion. At this point, it was thought that maybe it is just mnemonic effusion. So he was started on IV ceftriaxone and clarithromycin. Clarithromycin because his mycoplasma was positive. 2 days later, he was reviewed. He remained good. He remained afebrile in the ward, did not develop respiratory distress. On a review for the pleural fluid, it was shown that there was right-sided consolidation with moderate effusion with thin localized quantity was estimated to be about 270 ml, and couple of places they said thin loculi were formed. There was no internal echo at this time, or no dense deposits seen at this time. However, as this increased in size, IV linezolid was also added at this point, and a repeat ultrasound done the very next day showed mild pleural effusion, septations, low-level internal echoes, and the quantity had reduced, and the radiologist kind of reassured us that child was getting better. At this point, these were the lab parameters. On the day of admissions, the child had a total WBC count of 22,000 with PCT of 0.92. Mycoplasma, both by IgM and PCR, was positive. And 2 days later, when we felt he was clinically improving and also the ultrasound fluid was going down, his WBC count had also come down to 12.54. We were happy. Nevertheless, on review, another 48 hours later, the child started having some spikes of fever and his total WBC count rose to 20.44. And we went back and did our USG again, and it showed mild effusion with septations and internal echoes. At this point, we were wondering whether it is not responding to our current line. So instead of Clarithrol, we added levofloxacin. A CT test was done. Mild right pleural effusion with septations in the upper region was seen. Underlying consolidation and collapse of the right lower lobe was also noticed. So, just to show the CT, I hope it is visible. Yeah. So this was the CT picture and this was the image. In view of the loculi with some internal echoes, it was thought that it would be wise to do VATS, video scope assisted thoracoscopic surgery. That was decided to be done, and it revealed 100 ml of seropurulent fluid, which was drained. Several fibrinopurulent exudates were debrided, and the trapped lung was released. Chest tube was inserted. Patient showed rapid improvement. Post-op day 3 lab parameters normalized. He was discharged on post-op day 6 and has remained well on follow-up. The pleural fluid was an exudate with 100 cells per microliter, 80% polymorphs. LDH was high, protein was high, glucose was low. Now, just one thing to remember in empyema, we know that it's of 3 stages. Initial stage, first 24 to 72 hours, is the exudative stage, where the cellular content is less, the fluid is thin, needle aspiration can be done, ICD might be adequate, pleura and lung are mobile, and the pleural fluid, pH, glucose, LDH may be normal. The second stage is a fibrinopurulent stage, which may last from 7 to 10 days up to few weeks. Here the pus increases posteriorly and laterally, increased polymorphs and fibrin is seen, loculations are seen, lung expansion is restricted, and the pH, glucose are decreased and LDH is increased. The third stage is the organizing stage, where the fibrosis is much more and the membrane is formed and the lung is entrapped. Now, why is it important to know these stages? Is also to know how to deal with it. The first stage can still be managed by an ICD, but the second and third stage, where there are loculi formed, where there are thick exudates, it's better to go ahead with VATS for a variety of reasons. One, it breaks the loculi. Complete evacuation of the thick pus and fibrinopurulent material can be done. We can visualize the underlying lung and its capacity to expand. We can also see the presence, site, and size of any bronchopleural fistula if it is there. There's a faster resolution of fever, and the post-op recovery is also faster. Disadvantages, so-called, of course, are that the child requires GA, and you should have an experienced endoscopic surgeon well-versed in these procedures. It can be used as a primary or secondary modality after failure of the conservative treatment. Now, you might wonder that you're dealing with this day in and day out. So why this case? Why this case is that we have started wondering of late, was it all due to mycoplasma? In fact, I would like the esteemed members who are on this webinar to give their expert opinions. Is it all due to mycoplasma? Now, we know that mycoplasma infections have a cyclical pattern where they can come as epidemics, and mycoplasma pneumonia can present with pleural effusion. Some studies label it as high as 16 to 20%, though most of them are in the range of 5%. These are the more severe cases. Early systemic steroid treatment is helpful in resolution, and S pneumonia, strep pneumonia, and H influenza co-infections are more likely in those with mycoplasma pneumonia associated pleural effusion. Steroid response may suggest exaggerated immune response as the etiology. Now, of late, in 2024, we have seen just too many mycoplasma cases. I think the experience is the same when I discuss with some of the colleagues practicing in India. And CDC recommends the following for us, that we should consider mycoplasma pneumonia in patients with community-acquired pneumonia who aren't improving clinically on antibiotics that are known to be ineffective against M. pneumoniae, such as beta-lactams. We should perform the appropriate lab testing when we suspect mycoplasma infection, especially in hospitalized children, to ensure that we give them appropriate antibiotic cover. We should consider swabbing both the throat and the nasopharynx to improve the likelihood of detection in respiratory swab specimens. And consider using a second-line antibiotic regimen, fluoroquinolones or tetracyclines, depending on the age, to treat patients with suspected or confirmed mycoplasma pneumonia infection who aren't improving on macrolides. And we should promote frequent hand washing and covering coughs and sneezes to prevent bacteria from spreading. So, the global macrolide resistance in mycoplasma pneumonia is on the rise. If we see some of the figures, they say that it was about 18% in 2000, 41% in 2010, and in 2019 it has risen to 76%. A2063G variant is the most commonly associated variant with resistance found in, obviously, some studies. Resistance varies in different geographical regions, and as with so many other problems, this is due to overuse of antibiotics and highlights the need for antibiotic stewardship. With that, I finish my two cases, and back to you, Dr. Modi.
Madam, you can stop sharing.
Thank you.
Yes.
Thank
Just
you, ma'am, for the very two interesting cases. One is a very long course of complicated periorbital cellulitis, and another probably is a very interesting and drug resistant, macrolide resistant mycoplasma pneumonia. So now we'll have the privilege of our expert Balasubramaniam sir to step in and to have his comments, his insights and observations.
Yeah. First, my compliments to Dr. Kalpana. That was indeed a fantastic and complete presentation, I would say. Thank you very much for sharing those two very interesting cases.
Thank you, sir.
Yeah, that was brilliant. That was brilliantly presented by you. Congratulations. On the case one, I have a few comments to make. Basically, for the pediatrician, diagnosis of sinusitis itself is often a difficult clinical exercise. In fact, the best way a general pediatrician can diagnose sinusitis, in fact, I tell my students to remember a mnemonic, what I call PWS: persistent symptoms, worsening symptoms, and severe symptoms. I mean, this was published in one of the review articles in New England Journal of Medicine 10 years back, PWS. That is, any child who has persistent rhinorrhea, irrespective of the quality of discharge, lasting for more than 10 to 14 days with or without fever, you start thinking of bacterial rhinosinusitis, 1. 2, biphasic pattern, child who has a few days of catarrh, cough, tends to get better slightly, but continues to have and comes back with more symptoms. That is what you call worsening symptom. Third group is what like this boy had, severe symptoms. That is acute symptoms, high fever, toxemia, severe tenderness, mucopurulent rhinitis, foul smelling. That's what happens. It's very easy to remember. Only 5% of viral URI leads to sinusitis, and 5% of sinusitis only leads to complications. That is what is reported. In fact, there is an interesting study from the Scandinavian countries 2 decades back. They went on to do MRI of all normal school children. Okay, they found the MRI had shown evidence of sinusitis in 20% of them, but only 5% of those 20% had really had sinusitis. So it can be asymptomatic, even what is picked up in the MRI. Second is regarding the antibiotic choice for preseptal or periorbital cellulitis. It was interesting to note Dr. Kalpana had mentioned ceftriaxone and linezolid. I will tell you our protocol in our unit in Chennai is completely different. When we have periorbital cellulitis or preseptal cellulitis, we ask ourselves, what are the organisms that we should cover? Number 1 is, of course, rightly pneumococcus, streptococcus and staphylococcus, in less than 5 H influenza. What is more important to remember is that, as you had mentioned in the earlier study you had quoted, most of them are polymicrobial. Anaerobes also come into play. So our choice, if the patient is stable, we start ceftriaxone and clindamycin. If the patient is toxic, bacteremic, sick, we start with ceftriaxone, vancomycin to cover pneumococcus, H flu, anaerobes, and MRSA. In fact, we don't, I'm sure Dr. Modi and Dr. Rawat would also agree, we do not start linezolid in the initial coverage for sinusitis. That is my comment. Of course, it may be your local antibiotic policy based on your epidemiology, but based on our epidemiology, we do not give linezolid empirically initially unless we want to use it as a step down following vancomycin or following some other drug for MRSA. That's comment number 2. Third, 12-year-old developing a severe complication of sinusitis, I would definitely recommend you to do a primary immunodeficiency workup, however uncommon it is. In fact, your population is all pneumococcal vaccinated, and in fact, again, I'm quoting a Pediatrics article 3 years back, 10% of those children who develop invasive pneumococcal disease have been detected to have primary immunodeficiency. 10%. That was the incidence reported in the United States. It's pretty high. But now, I tell you, in 2025, if I see anybody with an IPD, I will not send the child home without doing primary immunodeficiency workup, including complement assay and looking for oval jelly bodies for splenomegaly. Because 12-year-old having such a severe pneumococcal disease, very, very unusual, I would work up for primary immunodeficiency. Next is X-rays of paranasal sinuses. I think this is a message to my pediatrician friends. Is one of the most useless investigations. Most useless. In fact, if you take an X-ray of paranasal sinuses, what can you pick up? You may pick up rarely a foreign body, which you would miss if you don't put your otoscope into the nose or examine with the torch properly into the nostrils or get a history. Second, you may pick up a deflected septum. Third, what are you going to pick up? Rarely you may find frontal sinus agenesis clue to cartilaginous syndrome. Last, you may find opacification of sinuses. Opaque sinuses, unless it is asymmetrical, if only one right sinus is opacified, left is normal, that makes bacterial sinusitis likely. But if both the sinuses are opaque, you can't say whether the sinusitis is bacterial, viral, fungal, or allergic. It only tells you it is that you can make a clinical diagnosis. So you don't have to waste your money. One. Second, you don't have to unnecessarily expose the child to radiation by doing a X-ray of the paranasal sinuses. Coming to this child, if I had seen this child, I would not have done a CT, I would have done straight away an MRI. CT is superior in MRI only if the ENT surgeon or the neurosurgeon or the ophthalmic surgeon wants to define the exact bony lesion. But otherwise, MRI is preferred to CT for diagnosis of orbital or periorbital or preseptal sinusitis. To avoid radiation, it's preferable to do MRI rather than CT. My last question to you, my question to you, madam, you grew pneumococcus from the pus and blood or only from the pus?
No,
and what was the total
yeah.
duration antibiotic that you gave for the child?
This was from the blood culture, and the pus culture actually grew Staph epidermidis, which the microbiologist was not convinced is a pathogen. Either ways, like in immunocompromised children or in those with indwelling catheters, we can see Staph epidermidis to be really pathogenic. But blood culture grew Strep pneumoniae, and it completely cleared off. Like the blood culture became negative even before we discharged this child. So this child received IV antibiotics for about 7 days, and then oral antibiotics for another 7 days. In fact, your doctor, any more points you would like to tell us, or?
These are my comments on the case number 1.
Yes.
On the case number 2, regarding the
Sir, before we go to the case number 2, can I just interject 1 minute? One more thing to which I forgot to mention is the use of steroids in this case as well. So even the literature supports the use of steroids after. Now that is tricky. They say after adequate coverage and after adequate improvement, they give steroids to reduce the edema. So once the child was taken up for surgery, steroids were used. As far as the comment regarding the X-ray, I'm fully on board with you. However, here we had tough set of parents who were just not willing to do anything further, and they were not willing for CT, and that was getting difficult. The CT was a choice really of the ENT surgeon who said they would like to see the bony anatomy, number 1. And then after the CT, they immediately said, I need an MRI before I can take up the child. In fact, we had a bit of a tip over there because I wanted them to do something surgically quickly, keeping in mind the deteriorating condition of this child. And linezolid was added in the point where the child was, where the parents were refusing the CT, and I wanted to increase the cover. The clindamycin, locally, we haven't seen very good in our antibiograms, not so great response, but yes, vancomycin we use quite often here, and it definitely works.
Okay. On case number 1, there was one question from the audience: did this child receive pneumococcal vaccine? I'm sure it would have received in the UAE.
Yes. But pneumococci have more than 100 serotypes. So,
Agreed.
Getting the vaccine is slow.
Yeah, that's not going to prevent rare sinusitis. Okay.
And the workup for immunodeficiency has been told to them, but these parents had it's a recent case and they've had a traumatic course. So they are kind of, probably going to take their time to come back for the workup. So it wasn't done, obviously, in the acute stage, but it did go through with them, that the child. However, at the same time, a 12-year-old child, there would be some immunodeficiencies that could come up, but without any significant past history, so of immunodeficiency related.
I'm afraid that concept is now gone.
Mhm.
There are immunodeficiencies diagnosed at 30 years, 40 years in literature. So in fact, I have seen reports of CGD being diagnosed in 40-year-old men. In New England Journal, I have seen one Massachusetts case
So,
records,
those are what
40-year-old.
my
So that
question
can
is,
happen. I think
yeah,
now
it can.
slowly now, it's like astrology. It's like astrology. Anybody who comes to you with some severe infection, days have
Mhm.
gone when we simply accept it as meningitis pneumonia. We should always ask why.
Bye.
Why in this child? Why this organism? Why this child is getting? So that's how we are picking up a lot more immunodeficiency than what we used to pick up 2 decades back.
Sir, excuse me, sir, I have one thing to know from you, sir. Sir, you told that beyond 10, if there is IPD, then we have all the reason to think of primary immunodeficiency. Sir,
No,
sir, what's your take?
Any age, Modi, it's not 10. Any age, I'll tell you, any age, in fact, I can quote literature. Any child with invasive pneumococcal disease. In fact, I'll also tell you one interesting reference. We say that 10-point agenda for primary immunodeficiency. Studies have shown only 3 criteria are enough to pick up immunodeficiency. One is failure to thrive. Second is family history. Third, you will be surprised. Receipt of IV antibiotics even once is an indication for workup for immunodeficiency. I can quote the archives article for you. Right?
Sir,
your sensitive, you see, your threshold should be very, very low to pick up immunodeficiency. Unless we pick up, nowadays, these are the days of genomics, we have facilities to pick up the diagnosis. We have facilities to treat and cure immunodeficiencies. So, any child with severe infection, you should look for clues, whether it is a barrier defect or an immunodeficiency or an atopy or a simple variation of a normal frequency becoming abnormally frequent. These are the 4 groups you have to ask.
Sir, what's your take on thinking of acquired immunodeficiency in this child?
No, acquired immunodeficiency, 12-year-old acquired immunodeficiency is very, very unusual. Very, very unusual. Unless the child has received the blood transfusion, unless the child belongs to the group of perinatally transmitted HIV with the bimodal presentation coming late, 12-year-old primary immunodeficiency, extremely unusual. You don't get, at least 15, 16-year-olds, you can say promiscuity might have started. You have to start thinking of your HIV, etc. Right? Subramanya has raised his hands. Yes, Subramanya.
Sir, congratulations to Dr. Sengupta. Recently, she was with us in that Dubai conference. Dr. Kalpana, if you could remember, that was a yeah. Now I could see Sir Balasubramanian sir. What I learned when I went to Dubai from interacting with the pediatrician is, it is not that they have got naive children. They have a lot of immigrant children. Somebody comes from US, they have to think in US style. UK, they have to think in UK style. Indian children, they have to think in Indian immunization schedule background. They receive half in Africa and come for rest half in Dubai. They have huge challenges as far as the epidemiology is concerned. And I would compliment her for extensively working up like that. And I think they can't have an antibiogram for Dubai. Rather, they should have integrated antibiogram from multiple places where they will have immigration challenges. This is number one. Number two is, Kalpana, could you just maybe probably Balasubramanian sir could also add, clinically for a pediatrician, between preseptal cellulitis and orbital cellulitis, I think it is important to check the pupillary sign. If the pupil is inconsistent in response to light, and if the movements of the eyes are restricted on either doll's eye or otherwise, then I think it is an ominous sign for a practicing pediatrician. Of course,
She
in a
mentioned that.
place,
She mentioned that. Subramania,
yeah,
she mentioned that.
she mentioned that. I think that's a take home for everyone, because sometimes we may or may not have the luxury of quick, referral to ophthalmologist, but in no way we can get away from not referring to an ophthalmologist or having a multidisciplinary approach in this patient. These were two of the comments. I think, sir, you can proceed further.
Yeah,
Sir,
yeah. Coming to the second, can we move to the second case, Modi, or you
Sir,
have any
sir,
more?
we have few more questions, sir.
Yeah, please go ahead.
Any specific doses or guidelines for oral steroids in RMPP?
No, we'll come to that. I'm coming to mycoplasma in detail. Don't worry.
Second case.
It's one of my favorite topics.
You
I'm
can take-
happy.
Yes, sir.
I'll come to that.
I know that.
I'll come to that.
Sir.
I'll come to that. Before, any other thoughts, Dr. Rawat?
Yes, sir. The only thing is that how common is staph in orbital cellulitis, because normally sinusitis is normally caused by staph pneumoniae and H flu. So staph as a cause of sinusitis, I think it is extremely rare. So a combination of ceftriaxone and clindamycin should work fairly well. There is no role of linezolid or vancomycin. These two should work fairly well.
No, it's usually polymicrobial, Dr. Rawat. Usually sinusitis, which leads to periorbital cellulitis or preseptal cellulitis. See, the flora is periorbital flora and oral flora of anaerobes, streptococcus, staphylococcus, pneumococcus, and H flu in unvaccinated children or non-typable H flu, right? It's in fact, Dr. Kalpana also quoted a study where most of the cases are polymicrobial. In fact, in such cases, the pus should be sent for even anaerobic culture, because anaerobes also there can coexist. That is one of the reasons why I said we use a combination of ceftriaxone, clindamycin for stable care. Clindamycin, we use it for two reasons. One, it's an excellent drug against anaerobes. It's an excellent drug for streptococcus, and it might work for as I said, epidemiologically in Chennai, most of the MRSA, nearly 50 to 60% are sensitive to your clindamycin. That's one of the reasons we use that regimen. But if your sensitivity to, as Madam said, if your sensitivity to clindamycin is very poor, yes, I wouldn't be using clindamycin, but at the same time, I wouldn't be using linezolid in the initial empirical choice. I would be only giving vancomycin in a sick child, and then de-escalate depending on the cultures I grow. Okay.
And the only second thing is that we should involve ophthalmologists very early, because orbital cellulitis the child can lose eye very, very fast. So
absolutely,
a quick involvement of ophthalmologist and surgical intervention, I think that is very important.
Yeah, surgical decompression is as necessary as prolonged antibiotic empirical coverage. Okay, right. Coming to mycoplasma, again, that was a brilliant presentation, Dr. Kalpana. We have gone through similar cases with dilemmas. Now, a few comments on mycoplasma. My comments may be rather out of the box. They may not be from literature alone. In fact, interestingly, I went through the net to find out about the incidence of mycoplasma. Is it going up? It is going up everywhere. And the reasons they say is because of the reduction in COVID, and also because increased awareness of the disease. In the UK, more reporting of mycoplasma pneumonia is happening mainly because they are doing more PCR. However, in a place like Chennai, Bangalore, Mumbai and all, even smaller hospitals have now reported PCR positive, clinically compatible mycoplasma infections. Definitely, the numbers are going up. The number of cases being recognized is also going up because we are doing molecular tests, we are doing IgM, etc. That's one. Second is, I think the term atypical pneumonia, I think should go from literature, should go from our discussions. For the simple reason, this term was given mainly because people compared mycoplasma pneumonia with pneumococcal pneumonia. And when mycoplasma pneumonia did not present with consolidation, did not present with the typical high fever, chills, and with the typical response to penicillin not happening, they called it atypical pneumonia. In fact, today, mycoplasma is behaving more like a typical pneumonia than like atypical pneumonia in the past. So it is
Agreed.
becoming more typical.
Agreed.
The term atypical pneumonia should go. We should call it as pneumonia only, because we have seen enough consolidation, enough pleural effusion, all proven due to mycoplasma. Coming to the incidence of mycoplasma pneumonia not responding to macrolide, this is a big dilemma for us. If you take statistics from China, Southeast Asia, Japan, the prevalence of macrolide resistant mycoplasma is to the tune of 70 to 90%. In India, unfortunately, not much data is there. There is only one paper from Chennai, from our government institution, where they had shown zero resistance to macrolides in Chennai. This was published a year back. That is the only data available in India. We don't have genomic data on the resistance pattern in India. I'm sure somebody must be already doing a study in India now, ICMR, another organization must be doing. We will know in future. But in India, so far, macrolide resistant mycoplasma is not so far a big problem. And Madam Kalpana very clearly said, whatever pneumonia we have, 1/3 is bacterial, 1/3 is viral, 1/3 is a coalition. Coalition of viral versus viral and bacterial, or viral and atypical, or typical and atypical. So it's not uncommon to find a PCR positivity or IgM positivity in any child with pneumonia. In fact, here again, there is a very interesting study which was published in US 10 years back. One crazy fellow went on to do PCR of nasopharyngeal aspirate in normal school children and went and did the same in children with pneumonia. And he published in Pediatrics saying that children in the school, they had 22% mycoplasma PCR positivity, whereas those with pneumonia only 14% had. So PCR may remain positive for up to 6 to 9 months following infection, symptomatic or asymptomatic. So PCR is not the gold standard. IgM may not go up in the first 6 days, and IgM may remain positive for up to 6 months. The Puritans will say that to confirm mycoplasma pneumonia, you should have the following. 1, a clinical picture consistent with mycoplasma pneumonia. 2, PCR positivity and 4-fold rise of IgG titers in 4 weeks, 4-fold rise, or a 2-fold rise in IgM antibodies over 4 weeks or 2 weeks. If all 2 or 3 of these criteria, along with a clinical picture compatible with mycoplasma is present, then only you can call it as confirmed mycoplasma pneumonia. In fact, Dr. Kalpana, we had a very similar case like this, pneumonia. One thing we did, we sent the pleural fluid for PCR for mycoplasma and also for antibiotic resistant. And we found that mycoplasma PCR was a positive in pleural fluid. Pleural space is a sterile space. If you have PCR positivity, it confirms the diagnosis of mycoplasma. I wish you had done this. If you had done that, you would have accepted that this is mycoplasma pneumonia. Okay.
Yes, sir.
And in fact, in our cases, 2 cases, we have done the PCR and found positivity. And both the cases, we also did the genomics for antimicrobial resistance. Both were actually sensitive to azithromycin. But mind you, they did not respond to azithromycin. I had to use levofloxacin. So coming to the last point, somebody has asked about mycoplasma resistant to macrolide and refractory mycoplasma. In fact, there are no, whatever data that is available regarding refractory mycoplasma, most of it is from China. How do they diagnose? You give macrolide for 3 days, child doesn't respond. Clinically, if you take it as mycoplasma, if you don't have any other diagnosis, if you don't have proof for some other infection, you should take it as macrolide resistant and try doxycycline or levofloxacin. Another 4 days, if the child doesn't improve, no other diagnosis, inflammatory parameters are bad, LDH is going up, the Chinese suggest you should think of refractory mycoplasma and consider methylprednisolone 1 milligram per kg for at least 3 days.
3 days.
Still, there is no response, no other alternative diagnosis. You give IVIG. That is a recommendation as per the Chinese data. But in India, in fact, I am yet to see a what do you call macrolide refractory or refractory mycoplasma pneumonia. Most of the cases, what I have seen, they respond to either azithromycin or respond to doxycycline or to levofloxacin. This has been my personal experience. But in the absence of PCR proof of infection, in the absence of PCR proof and genomic proof for macrolide resistance, only on clinical judgment, we have to change to use of doxycycline or levofloxacin, carefully keeping in mind that we should not miss some other diagnosis like staphylococcal pneumonia or resistant pneumococcal pneumonia or even tuberculous pleural effusion. These are my comments regarding mycoplasma pneumonia.
Sir, I agree with you, sir. I think the diagnosis of this mycoplasma pneumonia was made on PCR on nasopharyngeal swab. So if they would have done a ball or pleural fluid analysis, it would have been better. And then secondly, in this child, they didn't do ICD. Dr. Kalpana, the child had pleural effusion, the child was not responding. So the first step is that I think the child should go undergo ICD, where draining the pleural fluid and
Doctor, the very point of presenting one of the points was VATS, because the child had shown pleural effusion. It was not a long period. It was a matter of a couple of days, and the septae had already started forming. So pediatric surgeon had directly said that in this case, it is all better to do VATS, and that is the norm these days, because even the post-op recovery and pain and everything is much less in VATS. And that's what we saw. Whenever there are localized connections, they prefer to go. Otherwise, with ICD alone, they cannot break those septae, and that's the way to go about. So, sir, I also want to ask you one thing. All points are well taken regarding the mycoplasma diagnosis and treatment. In fact, when I was doing the literature review later, it did strike us that pleural fluid mycoplasma was not done, but I had to transfer the child to my sister concerned hospital nearby for a pediatric surgical intervention at that point. So my other question is about recurrent mycoplasma infections. We do see certain subgroup of children not accounting for the fact that mycoplasma is remained positive for 6 months and not true recurrence. Have you seen that some children are more susceptible to this than others?
I have not come across recurrent mycoplasma pneumonia in my practice, but you know, mycoplasma pneumonia, unlike other immunodeficiency defining syndromes like your pneumocystis or anything, mycoplasma also can occur with increased frequency in children with immunodeficiency, primary immunodeficiency. But I have very little experience in this. I have no data. In fact, even to answer your question correctly, I think we have to go and search the literature for connection between mycoplasma pneumonia and primary immunodeficiency. I'm afraid I don't know the correct answer. But having said that, PCR, I believe, can remain positive for as long as 6 to 7 months following an infection, symptomatic or asymptomatic. That is a problem. That's a problem. Yes. But as Dr. Rawat said, if you get it from the bar, if you get it from the pleural fluid or from a lung puncture or from CSF or from pericardial fluid or ascitic fluid or some other body fluid, joint aspirate, yes, that confirms the diagnosis. That's it. In fact, that is a great problem with regard to the diagnosis of so many other mycoplasma complications like your aseptic meningitis, transverse myelitis, autoimmune encephalitis, etc. The reason is you may not get PCR positivity in the CSF. You may get only IgM rise in titer or IgG rise in titer and PCR from the respiratory tract. So it's very difficult to diagnose the para-pneumonic complications of mycoplasma. That's the whole problem. That includes conditions like your Stevens-Johnson syndrome and our mucositis, etc. That is another big problem in the diagnosis of mycoplasma complication. At least in pneumonia, you have X-ray evidence of some pneumonia happening and you have PCR positivity. But in other organs, it's very difficult to prove that it is due to mycoplasma. And the
Sir,
Chinese
Balasubramanian sir, I have got a quick couple of things which I wanted to ask at this stage.
Just a minute, Subramanian.
Sir, please.
Yeah, at the moment, it is really not known. It is not known. I'm quoting literature exactly. It is not known whether antibiotic treatment influences the outcome of para-infectious complications of mycoplasma. For example, transverse myelitis, okay, Guillain-Barré syndrome,
Autoimmune
okay, and all those complications. It is not known whether antibiotics really alter the course. Even in uncomplicated lower respiratory tract infection, there is no evidence that macrolides really alter the course of the disease.
Yes.
In severe pneumonia, there is evidence that it might improve the outcome. Whether how it improves the outcome, whether it is because of the antibacterial effect against mycoplasma or because of its anti-inflammatory action, nobody knows.
Sir,
Sir,
what
two quick points. I wanted to just ask Balasubramanian sir and Kalpana also. One is that we must be looking for pulmonary thrombotic complications in pneumonia, probably some 2D echo, something like that, or some other imaging should be kept in mind, number one. Number two, in this case, we had a loculated pleural effusion. So that keeps lower the chances of tuberculosis and mycoplasma than considering for strep pneumonia and staph. Perhaps I think Balasubramanian sir, I am still under the impression that once it is loculated versus it is unilocular, any clue to the etiology? Please, your comments.
No, the Chinese beg to differ. They say the commonest cause of necrotizing pneumonia they are seeing in children is due to mycoplasma.
Then it's
I don't think presence of loculation rules out mycoplasma pneumonia.
Fair enough, sir. Thank you.
That's what I said. See, gone are the days mycoplasma pneumonia behaved silently and in a very disciplined manner like atypical pneumonia. It has started presenting as typical pneumonia. That's one message to the audience.
Yes.
Sir,
other
Dr.
thing I
Kasi
think-
Bandaru and Dr. Silpa Hajare, they have been raising their hands for a long time. Please.
Sir, can I ask?
Yes.
Sir, pleural effusion is generally an inflammatory reaction. So, what is the sensitivity of PCR positivity in pleural effusion? Because there could be mycoplasma infection actually, and still pleural fluid PCR may be negative.
Oh, see, two things. I'm afraid I don't have the literature based answer for you. But having said that, see, if there is a mycoplasma pneumonia severe enough to produce an effusion, and if you find PCR is positive in the pleural fluid, that confirms the diagnosis. On the other hand, PCR negativity in the pleural fluid does not rule out anything at all. For example, we take tuberculosis. In tuberculous pleural effusion, less than 5% will be IAP positive, because we all know that it is a hypersensitivity reaction. It's a paucibacillary disease. It's a disease which occurs in people with good immunity. On a similar note, in mycoplasma, I don't have, I'm not read data which suggests that PCR will be negative. But most Chinese data suggests that in pleural effusions, if you do a PCR, if it is positive, it confirms mycoplasma pneumonia. That's all I have. That's all I know. Maybe I'll have to go and look up further.
There is no percentage wise, no study says that what percent will be positive.
I don't know. I'll search literature. You send me, you SMS your mail ID. I'll send the article if I find any. I'm not read anything like that.
All the PCR platforms in India, like for example, BioFire, they don't accept the pleural fluid as a specimen for PCR. They want nasopharyngeal or BAL. So they
Correct.
don't accept pleural fluid. So all the platform which we use in India, like BioFire, they will not accept pleural fluid as a specimen. They want BAL or they want nasopharyngeal. So we cannot do it here.
Dr.
Yes,
Kasma
for
said this.
even a study to be conducted in that lines, we need a gold standard. As Dr. Balasubramanian's experience goes, the gold standard is also shifting from gold to silver and back to gold. So therefore, I think it is difficult to get a sensitivity, specificity, positive and negative predictive value, which you are asking.
No, ultimately, having argued so much on this, ultimately a wise clinician, okay, treats a pneumonia as mycoplasma pneumonia on clinical grounds.
Yes, sir.
3 days you use macrolides, child is not responding, you still think it is mycoplasma, let the PCR be positive, negative, IgM be positive, negative. I will definitely change over to levofloxacin or doxycycline on clinical grounds, provided I am not missing a tuberculous effusion, a fungal effusion, an effusion due to a malignancy. That's all. That's all that is required for a pediatrician who wants to be rational. No, investigations may not rescue you in every way.
Yes.
You have to use holistically your clinical judgment and experience to get rid of those puzzles.
Sir, last comment by Dr. Kasi. Dr. Kasi. Dr. Kasi.
Sir, regarding the first case, I totally agree with Balasubramanian sir. A 13 years old child should not develop an abscess. If there is an abscess, definitely we should suspect a PID in this child. But the point here is, sir, like madam, like the presenter Kalpana madam, madam, nowadays the practice is very becoming diluted and all. So you have to identify what is the culprit at the first presentation itself. Here, what no, madam, why I'm raising this question is, if it have been primary immunodeficiency, again within 2 or 3 months, the child will land up with another abscess. Either it may be the empyema or it will be bone abscess, any abscess and all. So what I feel, sir, like we have to have an eye suspicion, and you have to inform to the parents that in case if it is a primary immunodeficiency, this child may have one more severe attack like this. So it may require a prophylactic antibiotics. So this is what what I feel, sir. Coming to the second case, sir, it is a one side pneumonia. It's a consolidation with the septations and all. Why can't be a streptococcus pneumonia, sir? Which is still in India, it's a very common streptococcus pneumonia.
No, see, Streptococcus pneumonia, the pleural fluid culture would have given a clue. Of course, antibiotics have already been given, you may not get it. It could still be streptococcal pneumonia. See, but you must remember, as I said, 1/3 is a combination of pneumococcus and virus and pneumococcus and mycoplasma, right? The possibility of a dual etiology for pneumonia remains very much there in practice. So that is why most guidelines, whether it is British Thoracic Society guidelines or IAP guidelines, any pneumonia, 48 to 72 hours, if it does not respond, particularly above the age of 5 years, you should start suspecting atypical or mycoplasma pneumonia, and you are justified in giving macrolide. But the biggest problem is, below 3 years, the same does not apply. Below 3 years, your mycoplasma is not very common, it's extremely rare. And below 5 years, you are not supposed to use only macrolide for pneumonia for the simple reason, if it is pneumococcal pneumonia, it may be a bacteremic pneumonia. For bacteremic pneumonia, macrolides are poor because they are bacteriostatic. So you have to use a beta-lactam and a macrolide. So that is why most guidelines say 48, 72 hours non-responding pneumonia, beta-lactam plus macrolide is the drug, is the combination of choice. In an adult, respiratory quinolone, which covers pneumococcus, which covers H flu, which covers your MSSA, which covers chlamydia, legionella, and your mycoplasma, you get away with levofloxacin as a single agent. In pediatrics, we should not be using levofloxacin so liberally. We should reserve it for
TB.
macrolide resistant pneumococcal, the mycoplasma pneumonia proven or PCR positive cases which do not respond at all to macrolides or doxycycline. And most literature reports say that the response to treatment for mycoplasma pneumonia usually happens in 72 hours.
Sir, in
Yes.
the second
Sir,
case
yeah,
of Dr. Kalpana, sorry, sir, in the second case, they started with ceftriaxone and clarithromycin. Then they went on to add linezolid, then levofloxacin. Sir, what do you do with the previous antibiotics? Means first antibiotics that they started.
No, I see. I don't think I will give a combination of ceftriaxone, clindamycin, linezolid, and one more drug you said. What did you say?
Levofloxacin they
It's not
started
all-
last.
I don't think it
These
is
are not
rational to give
added,
everything
doctor.
together.
The
I don't think it
antibiotics-
is rational to give everything together. Okay.
No, not at all. They were changed. The antibiotic was changed. When, like I said, initially for 48 hours, we were very happy because the child clinically improved. The lab parameters improved. Even the pleural fluid on ultrasound came down. However, when the fever started creeping up, the pleural fluid again increased the very next day. That's when the antibiotics were changed. They were not added on. Definitely not.
Madam, I agree with you. I would have definitely given macrolide to the child. And if the child had not improved with macrolide, I would have gone in for doxycycline. Particularly the child is above 8 years of age. And if it is a child above 7 years, definitely if doxycycline doesn't work, I would have considered levofloxacin. I agree with you.
Sir,
And
in
the other
pneumonia,
thing is-
sir, in pneumonia, you wait for 48 to 72 hours to go on to a macrolide, suspecting mycoplasma pneumonia.
No, but if there is fluid, you put an ICD, that is very important. If you don't put an ICD, you will not respond at all. So first thing, if there is fluid, put an ICD.
Agreed.
That is true.
Antibiotics alone. See, if you see, Dr. Modi, the easy way to remember for practice is, if your pneumonia is not responding to your initial antibiotics, you put the blame on 4 different places. First, put the blame on the clinician. He may be making a wrong diagnosis. 2, put the blame on the bug. You must be trying to hit the wrong bug. 3, put the blame on nature, antimicrobial resistance. Last, 4, some complication. One of the 4, you will pick up a clue. You have to ask yourself, where is the problem? Whether it's a wrong diagnosis, whether it's a wrong pathogen you are hitting, whether it is a antibiotic resistant pathogen, or is it some other disease, non-infective lesion. You may be treating a leukemia with infiltrates in the lung as pneumonia. It may not be leukemia, it may not be infection at all. It may be Langerhans cell histiocytosis presenting with interstitial pneumonia. Antibiotics won't do anything. And last but not the least, if there is an abscess, if there is a surgical complication like empyema, only surgeon can cure it. Physician cannot cure it. As simple as that. You have to find out where the problem is and correct the error.
Thank you, sir. It has been an excellent session. Dr. Modi, please give vote of thanks. We have already overshot
No.
time. Please.
Rawat sir, only one question
Sir,
last,
we overshot
please.
time. Sir, we overshot time, please, sir. We overshot
30 seconds, one question to Balasubramaniam, sir. Last question. Sir, when a surgery like FES is done, does the pediatrician or the ENT surgeon decides the antibiotics? And in post-surgical cases, often it goes to the protocol of the ICU, or is it that pediatrician has got a say? One line from you.
Pediatrician, definitely. And a pediatric ID expert. Yeah, as simple as that.
Dr. Modi,
Thank you,
please,
sir.
vote of thanks.
Thank you so much. And thank you, Dr. Kalpana ma'am, to have actually made two very interesting case presentations. And hats off to our own teacher of teachers, Dr. Balasubramaniam sir, all the dearest delegates, Subbu bhai, everyone joining in and making it a very enriching experience. Thank you all. Good night.
Thank you. Good night
Thank you
all.
so much. Thank you, sir.
Fantastic presentation, Dr. Kalpana. My compliments to you.
Thank you, sir,
Thank you,
for
sir.
all your
Thank you, sir. Good
insights.
night.
I learned a lot today. Thank you, sir.
Bala sir,
Kalpana,
thank
bye-bye.
you. It's always
Bye-bye.
a pleasure
Thank
to
you.
listen
Thank
to
you.
you. Thanks a lot.
See you all in
Excellent
Dubai.
presentation. Thank you. Yeah. Thank you.